Good morning, and today I'll be talking about injury to the bowel. It's a serious problem, especially when you work in a high volume trauma centers like your apex trauma centers or your district or state headquarters hospital. Not only that, you may be working in a very good neurosurgery setup. You will get head injuries along with a very subtle bowel injury. Those are the ones which will be running a course below the surface and cause havoc in patient outcomes. And when diagnosed late and treated late, they cause a lot of morbidity and sometimes resulting in mortality also. So why did I particularly choose injury to the bowel? Because many a times these injuries have been missed. One, because they have not been thought of. And number two, patients would have been put on non-operative management for solid organ injuries. And then once they sink, they will be referred out to a definitive care. So there are a lot of pitfalls there. We need to look into all this. Now coming to, when I say bowel, it starts from the ligament of Treats. The ligament of Treats is somewhere there, involves whole of the small intestine, the large intestine, up to the anus. So it's very broad. Now I'll try to give you as much a generic explanation as possible. Now difficult for me to cover injuries to the duodenum, injuries to the jejunum, injuries to the right colon, injuries to the intraperitoneal rectum, extraperitoneal rectum and anus. So it will be sort of a very broad overview of injuries to the bowel. Now I want to re-emphasize these online sessions are only to facilitate and support your clinical skills, never to be considered a surrogate. Now I do find students, some of the students, not all of them, they sort of got some sort of assurance that AI is going to come and help them. Even though I talk about AI is only a beautiful tool if used wisely. Now, please don't outsource all medical problems to AI and think it is going to solve it for us. Not at all. So, as students, please invest a lot of time in gaining clinical skills. Thank you, and we can proceed with the rest of the presentation. So as I told you, it's going to be a generic description. The whole length is going to be 6 to 7 meters and very difficult to confine to exact anatomy. Now, as I told you, this is only an overview of traumatic bowel injury, very generic. It's a significant clinical concern and often resulting from blunt or penetrating trauma. Sometimes it can be a combination. Somebody got punched and knifed, or somebody fell from a height onto a penetrating object. So you need to understand the mechanisms, presentation, and management strategies naturally to offer effective treatment. Now, out of these, small bowel injuries are the most common, which will be including perforations, serosal tears, or complete avulsion from the mesenteric root. Colonic injuries are less frequent because they are sort of protected in the retroperitoneum, but the small intestine is very mobile. And mesenteric injuries can lead to ischemia and require surgical intervention. Now, mesenteric injuries can bleed on their own and cause features of blood loss and peritonism. Or the injuries may be that they cause ischemia to the bowel itself. So they may not be primarily due to blood loss, but the features are ischemia to the bowel. Now this is our own study. We found that abdominal injuries were about 10%. And out of this, 2.9% were hollow viscus injury. So when I mean abdomen, it means the spleen and the liver and the kidneys and the retroperitoneum. Out of this, hollow viscus injuries was about 2.9%. Now, if you look at it, we had more hollow viscus injuries than we had comparatively more hollow viscus injuries than the Western literature, because solid organ injuries are usually due to acceleration and deceleration that happens during speed. But our injuries were not because of speed, they were basically crush or run overs. So naturally the bowel is injured there. Now again our study. The most common will be the jejunum and ileum because they are relatively very free floating, unlike the duodenum or the fixed ascending colon, descending colon, or the extraperitoneal rectum. Sometimes they will have multiple injuries. The jejunum will have perforations, the intestine, the colon, etc. Now, more important is associated major injuries. Have a look. Associated major injuries. You see, none of them come isolated with just one perforation in the jejunum. That may happen in a very low velocity stab, but most of them will be associated with a fracture femur, a pelvis, severe head injury, severe injury to the thorax. So you have a multiple problem at hand. The main problem is the bowel injury. So as I told you, it's from grade 1 to 5. I'm not going to go into the detail. It is just I'll be reading the slide. That is not what is needed now. I need to bring the concepts. So now what about the clinical presentation? Of course, abdominal pain, tenderness, distension, either bleeding upper GI or lower GI. Physical examination may release a tachycardia in the general, and of course you might get abdominal findings, Cullen sign, Gray Turner sign, and a whole lot of other things to diagnose blunt injury to the abdomen when you have these physical signs. Now, most important, what I want you to know, sometime your patients will be always in a spectrum. Anything. Your pneumonia patient will be in a spectrum. Your Guillain-Barré will be in a spectrum. Your trauma to the spleen can be in a spectrum. You might have patients walking green, but having an abdominal injury, all right. They may be healthier than the surgeon doing the shift that day. You see this man, he had a vault of gastric perforation, but he is, the moment we admitted him, because he had clinical findings, but he is on the phone with a Rice tube there. Or they can be sick and in early shock. Or you can have the bowel hanging out coming to the accident and emergency. Or you might have patients in extremis. This is beyond red. This is almost in cardiac arrest, not even almost. It is already in cardiac arrest. And you can see the bowel eviscerated out. Now what I'm telling is, these two you will have no problem diagnosing. Layman will pick up. This may be a little bit, you may not be, you may be a little caught off guard and you may not pick up early shock. But these are the ones which you will miss and send them home and they will come back like this. This is where the problem comes. But if you are careful, you may pick them up at this level itself. You will go deeper than this picture and pick him up and handle him before you send him home and he comes back to you like this when it's very obvious to diagnose. So where do they show up in the primary survey? Immediately in the ABCDE. They may show severe intraperitoneal hemorrhage in the C itself, or there can be an external wound, bleeding. Now, where do they show up? In the primary, suppose he's treated somewhere else and he sent you after 24 hours, you will again do the primary survey. Each time you encounter, you will do a primary survey. That time, they might be in septic shock. So naturally, they will be in circulatory problem only, or they may be even disoriented. In isolated bowel injury, some of them come even in extremis after a delay. Even a blunt injury, no external signs, no bowel hanging out, they may come in extremis because the shock and the bleeding has not been addressed adequately. So there's something known as a seat belt sign. Now we obviously don't have a seat belt sign, but you can always look for it in the clothes that they are wearing. Now, whenever there is a seatbelt sign, there is a 4 to 10-fold increase. Look at this lady, no seatbelt sign, but a pallu caught in a conveyor belt. You see the sign here? So this is part of the seatbelt sign. You can assume it to be a seatbelt sign. And when we knew, of course, she had abdominal findings, but this is, even if she didn't have an abdominal finding, she would have gone for a CT for evaluation. And it showed multiple perforations, not only that, pending perforations in the small bowel. Now, there's something known as a chance fracture. Whenever you find a chance fracture in the lower dorsal spine or the lumbar spines, always look for clinical findings in front of the fracture. That means the pressure here or the force exerted on this spine was so much that there was a blowout fracture. Now that is not going to only confine to the spine. That force is also going to go to the root of the mesentery and the bowel walls. So they need clinical examination, more so when they are put in non-operative management. They will need serial examination and also look into the CT keenly and pick up bowel problems. So this is the patient's chance fracture. He also has almost a low blowout in the jejunum and the ileum. So whenever you find these, even if you don't find abdominal findings, please be on the lookout to get the abdominal findings clinically as well as use your imaging liberally. So now what are the methods by which you can sample the abdominal cavity to find out whether there is a significant intra-abdominal injury? One is your clinical examination. But what if you don't have a clinical examination or you have a clinical examination which is equivocal? Equivocal clinical examinations will be found in the very elderly, the very young children, if they have a distracting injury or if they are having altered sensorium. So you can do a DPL, a FAST and a CECT. Out of these, the CECT will have high sensitivity and specificity. Now what I want to tell you is there is a buffet of diagnostic procedures. Your clinical suspicion is high. Don't stop with one. Go for the other also. Now can AI help? Yes, AI can help trainees. Like your diagnostic peritoneal lavage, right from the time you put the needle. And it can also read the slides without going through the rigmarole of staining and getting a pathologist to look at these findings, like your number of RBCs, whether there is fecal matter, vegetable matter, etc. Now, AI will also help in CT interpretation. Very important, because not all the time you'll be able to interpret the CT so rapidly, more so when you have 5 CT scans at the same time in disaster management and you want to read them fast. It can help you. You cannot outsource it. So as I told you, your diagnostic peritoneal lavage, AI can help, because individually about 30 years ago, we used to do the DPL, carry the sample to the lab and put it under the microscope and break our heads in the middle of the night, and half the time the results were wrong. We were still proceeding clinically. Now AI has come and sorted of helped out. So what about CT scan? You can find free intraperitoneal air. There can be bowel defects, a whole lot of things. Now, the ability to grossly access the wall thickness, pericolon stranding has its limitations. So it's not that easy. Similarly, your hematomas. This is a huge hematoma, mesenteric hematoma. But what if it is small? You will miss it in the cuts, but your AI will be able to take you there and park you there so that you give a second look or a third look or call for a second opinion also. So performance of CT in detection of the bowel, yes, with the search, do not provide a specific misby, but it has been detected by AI. So I told you, when you have rigid hierarchies, like in your malignancy, you would probably do an X-ray chest or an ultrasound and then go for a CT or a PET scan. But in trauma, yes, you need to have some sort of hierarchy. But depending on certain situations, you can always come back and pick up the other investigations lower in the hierarchy if it's going to help you. I'll give you an example. The gold standard of determining if a trauma patient has sustained a bowel injury is the setting of non-diagnostic imaging, but a high clinical suspicion is serial abdominal examination. Apart from your imaging, the one other very good weapon you have is to serially examine. Now, look at this patient, patient X. CT was normal, but vague abdominal findings persisted. It is not clear-cut peritonitis. It will be just one small tenderness here and there, and patient will go hoo and ha. That's all. CT was normal, but because findings persisted, we did a TPL, which came out to be positive, posted. You can see a transverse mesentery cut, and naturally this bowel had become gangrenous. Now, this patient had a transverse tear on the mesentery. There was no bleeding, nothing to affect the vitals, no perforation, so no peritonitis. Findings were not clinically florid, but these are the ones which will go into early organ dysfunction. It will creep in very stealthily. So these are the problems or pitfalls in management of bowel injuries, which you can use these to work around the issues. Now this is another patient, blunt injury to the abdomen, so female adult. Ultrasound showed minimal free fluid. Now this minimal free fluid can be coming from a small tear in the spleen which has stopped. X-ray chest supine, no free gas under the diaphragm. But peritoneal signs are persisting. Hence CT after 24 hours and you find free gas here. These are important. See, this is Common General Hospital. These are important clues. So what I want to tell is serial abdominal examination is very, very important. And that cannot be replaced by AI in the near future or even in the far future. This is another patient. Adult lady, abdominal trauma, peritoneal signs, had free fluid on USG, no obvious solid organ injury. Plain X-ray as usual, supine in trauma, no free gas. But you can make them sit up, provided you are able to make them sit up after clearing C-spine. Radiologically, you made them sit up and you found free gas. Now you can do a laparotomy. Otherwise, with just that little bit of free fluid, you can't be doing a laparotomy. It will become negative laparotomy or non-therapeutic laparotomy. But with this, you know this needs a laparotomy and it's going to be a therapeutic laparotomy. So now, what was the delay in diagnosis, delay in imaging, delay in manifestation, and distracting? So eventually, only 75% were positive after 8 hours. This is very important. Some of the patients come very early to us. They are admitted either as head injury or just like that for observation. Now, 75% may not throw up a finding in the first 8 hours also. Be careful. Now, what happens? The more elderly, they took longer time to manifest. You can see the elderly all sitting here in the graph, in the cluster graph. So, especially elderly, do your serial examination more often with them. Admit them. Especially government hospital, no problem. Corporate, all the more you admit, your administrators will be extremely thrilled. That is the end of part 1, where I only talked about the presentation and the evaluation and the mechanisms. Now, you must, lot of emphasis on the presentation, as I told you about the spectrum they can present with. So always as a doctor, you should be able to pick up subtler clues. Obvious clues, anybody patient himself will pick up. But subtler clues is where your expertise will be very much appreciated. So now please do look out for part 2, which I will be uploading soon, and that will be talking about the intraoperative management and the complications. Thank you, and as usual, please subscribe to my YouTube channel.